everyone. Welcome back.
Chairpersons, for the next session, may I please take the honor to invite Dr. N. Junior Sundaresh, Dr. Satish Midha, Dr. Shehzad Alam, and Dr. Dinesh Kardam to please chair this session.
Good morning, everybody. So first speaker of this session is Dr. Abhilash. He'll be presenting on TAPP, technique and innovation.
Good morning, sir. So I'm Dr. Abhilash, once again, consultant GI laparoscopic robotics. I'll give this talk on his behalf. So I bring greetings from Gleneagles Hospital, Chennai. So what we are going to see about today is about the robotic TAPP repair. So primarily when we concentrate on groin hernia repair, these are the fundamentals. So your diagnosis needs to be accurate and you need to select the correct patient for the surgery. For example, an old man who is admitted for some other problem with an asymptomatic hernia who is probably close to 90 years, you don't want to operate on him. So correct patient selection is important. Then surgical approach, whether open or minimal invasive, is important based on the patient's criteria for fitness for anesthesia. Then when we are doing the surgery, adequate exposure of the anatomy and dissection is very vital, and mesh placement is going to be important. What is the size of mesh, what is the nature of mesh, medium weight, heavy weight, lightweight, what we are going to use, and what you're going to use to fix the mesh, whether your suture or a glue or a tacker is important. And you always have this mind, do a tension-free repair and identify and protect the key structures, whether it's open or minimal invasive. And the main thing you need to avoid is hemostasis and seroma formation, which can lead to infections and mesh rejections later on, and the closure of the wounds appropriately. So can I have the control? So coming to minimal invasive repair, we've been doing laparoscopic repair, and now with the advent of robo and the penetration of robot into many hospitals, we have started doing robotic repair. And compared to TAPP is more preferred in robo because the suturing and the dexterity of the instruments is very convenient with the robot, so we always prefer to do a TAPP. And also we can see the other side. When we go for a right side hernia, you might also look into the left side when it is a TAPP repair, and you can do a simultaneous repair when you feel there is another hernia on the other side which was not detected clinically. So the comparison sake, laparoscopic robotic, both you need to be thorough with the anatomy of the groin from the back side, and lap has a deep learning curve, but robo is very quick and very simple to master, and ergonomic challenges are always there in laparoscopy, but in robotic surgery you have comfortable ergonomics. And lap you need a skilled camera assistant, but robo you control your camera, and there is 5x magnification in lap, but whereas it's 10x, and you have even 3D with robot. And tackling the sac is going to be sometimes difficult in laparoscopy, but in robotic the job is little easier. And mesh fixing options, you have tacker, glue, sutures, but in robo we always do only suturing. So this is the patient position ideally in the Trendelenburg position, and these are the 3 common robotic ports we use, and these are 8 mm ports placed about 4 finger breadth apart along a transverse line just above the umbilicus. So normally when you start with, you do the peritoneal opening. So we start from around the ASIS and we start dissecting medially. So the common instruments we use is bipolar, either a fenestrated or a forced bipolar, and we use the monopolar scissors. Some people even do use the hook also, but we prefer to use the scissors most of the time. So usually you can a little bit, if you open the peritoneum, the pneumo is going to fill up the extra peritoneal space and make the dissection further easier as you progress later. And because of the 3D vision and more magnification, you cannot make this out, but once you sit in a robotic console, you will see how good you are able to perceive the anatomy well with the help of the robot. So once you open the flap up to the medial umbilical ligament, you progress towards the inside, and So here it is a direct hernia. So you can see you are leaving behind a thin bit of fascia on the top. You don't bare the roof, expose the muscles. Even the inferior epigastrics are covered with the fascia here. So you leave this behind just because you don't want to injure those structures, and it is always safe to work in this space, and there is very minimal bleeding in this space. And as you see medially, much of the dissection is done with the help of only these two instruments. You can apply a gentle traction with your bipolar and use your curved scissors to do. And you don't have to leave and grasp very often. And because you are only having one holding instrument, the other instrument is constantly pushing. So you can even do the dissection with the help of the scissors, not only cutting. With short bursts of cautery, you can easily dissect, and you can push the complete direct sac here. As you can see, we are using your left arm efficiently, pulling down the peritoneum, and the entire sac is being pushed into the direct hernial defect. So as you progress here, then you come to the cave of Red CS and make space at least 2 centimeters below your pubic arch, and you can see how thin the peritoneum is on the lateral side. And always try to leave behind some fascia on the lateral wall so that you don't expose the nerves and your mesh doesn't come in contact with the nerves. And then you can deal with the cord and the vas after this. Okay. So this is an indirect sac dissection video, and here you can see the indirect sac is being reduced with the help of the grasper and with the help of the scissors. Usually in long-standing indirect sac, either the vas or the testicular vessels, your gonadal vessels might be stuck to the sac very densely, and it is very difficult. Sometimes you might end up injuring the vas or your gonadal vessels most of the time. But with the help of the robo, your magnification is good and your movements and your dexterity is very fine, so you can try to save the like you can preserve the cord structures and the avoid damage to the testicular and the gonadal vessels as much as possible with the help of robotic instruments. So, and with also you can see there are certain markings made from the outside, because this, if there is a mentor or another surgeon standing outside, they can make these markings on the monitor, and they can show you where to dissect and where to cut, and you can see how badly the sac is stuck to the testicular gonadal vessels. We are able to dissect it off completely. You are only holding the sac, you don't handle the vessels, and you can smoothly dissect off the sac completely away from the vessels. You can even use a bit of a gauze piece for fine dissection, and to avoid the bleeding, you can absorb the blood so that your field doesn't get messy. So use a gauze and you can do the sac. So we are able to completely dissect out the indirect sac, because only in certain cases you might have to compromise on the vessels, or you might abandon the sac, and it might lead to seroma formation and other things. But when you have a robo, you have a good chance of dissecting out the sac completely, so that you can avoid a seroma formation. So almost completely we have dissected out the sac in this, and this is another video on the this is a lateral dissection video. This you can see the space of the bogros. Normally when you dissect the lateral half, as I told you, don't leave the muscle bare. Always try to leave a thin bit of fascia on the sides so that the mesh doesn't come in direct contact, so that you can avoid forming causing chronic groin pain or a neuroma or an irritation later on. So preserve this bit of fascia or the deluxe fascia on the lateral wall in the space of bogros. And mesh placement, you can use any of the meshes, and we sometimes prefer to use the 3-dimensional mesh, which is very easy to place and deploy. As you can see, just put the mesh there, and it automatically, if your dissection is good enough, automatically the mesh sits in the correct space very easily, and you can start fixing the mesh. As I told, because we use the robo, we don't do glue fixation or tacker fixation. Laparoscopy, sometimes for the want of saving time, we might end up fixing with tackers, which can cause some kind of chronic groin pain in certain cases. But here we are only just doing some loose suturing of the mesh with the help of PDS or a vicryl suture material. You can fix the mesh to the coopers. We normally prefer to do a 3-point fixation, one to the coopers and one to the anterior abdominal wall on the medial side and one on the lateral side. We also have this suture cutting needle holder, but unfortunately we don't have that device, so we sometimes end up having an assistant to come in and cut your sutures. So, but if you have a suture cutting needle holder, large needle driver, mega suture needle driver is there, which you can suture and cut with the same instrument. So 3-point fixation has been done medial, lateral, and one at the Coopers. So peritoneal closure is very simple, very fast. You might take a lot of time in peritoneal closure in lap surgeries, but in robot it's very easy. So one side we use a 15 centimeter barb suture material, and once you start you can take multiple bites in one shot, and then you can just give some traction, pull it and tighten it. So you need not take one stitch and tighten the suture and then pull again. So at one go you can take multiple sutures and then pull them and close the peritoneum completely. So we've done the entire closure. And if it is a bilateral hernia, there is an option you can use you can take a 30 centimeter long suture material and you can start dissecting, like start closing from one end and cross over to the other side with the same suture material. So this is an example of a closure of a bilateral hernia. So we start from one end, so gradually move on to the midline, and at the level of the midline what we do is we try to cross over to the left side also. So you can see here through the medial umbilical ligament you can take the needle to the opposite side above the peritoneum. Don't come intraperitoneally. You might sometimes leave behind a loop hanging inside. So extraperitoneally bring the needle to the opposite side, and in this case it was a bilateral hernia. We started with the same thread, we started suturing the opposite side also. So the ergonomics is very great, so you don't feel tired. The same thing if you do by lap, your shoulders start aching after the end of the suturing. But the same thing in a robo, you are very comfortable to do the entire thing, and you can completely close the peritoneum. Okay, so the outcomes usually it is lesser post-op analgesia requirement as per our experience. The patients were discharged on the first post-op day, and less frequent post-op visits also. Sometimes patients with some kind of a pain, you follow the principles properly, you don't use stackers, then the patient has barely any pain. If the patient has pain, they keep coming back to you more often for more OP visits. And less chances of serum formation, because you can maximum try to dissect out the sac instead of abandoning the sac in most of the cases. You can plicate a direct sac, prevent the serum formation. And also because of the size of the ports, you don't use a 10 or a 12 mm ports. Chances of hernia formation at the port site is also very less in robotic TAPP. So take home points, choose your patients carefully. And the problem is now because of the cost, not many patients might be able to afford the robo. But I think with more companies coming into the market, with Indian brands coming, the cost is becoming cheaper and cheaper. And once you cross the learning curve, you can finish off a hernia in even 20 minutes. And insurance consideration, some insurances have started giving approvals for hernia surgeries, but not all insurance companies give the approval straight away. And you also have to choose the patient carefully. For a simple, straightforward, direct hernia, you might not treat the robo, it might be an overkill. But bilateral cases, complex inguinoscrotal swellings, recurrent cases, robo might be a very good option. So ultimately, who benefits? Definitely the patient. Also the hospital is making some more money, and the doctor is also happy, and you cross your learning curve, and you also make good thing from the surgeries post later on. And always try to have data and try to publish your experience so that it will be useful for the future generation of doctors coming in. And thank you.
Thank you, Dr. Vilas. One question from my side. Dr. Vilas.
Yes, sir.
Tell me, what are the innovations you want to reflect in this presentation other than the robotic surgery?
Sir, innovation is, it is, as I said, instead of using the hook, the scissors, because of the flexion of the scissors to close to 90 degrees, and it is not a grasping instrument, but with the help of flexion, you are able to give some traction and hold it with the scissor itself. You don't need to take another grasper, like we use 2 graspers in a lab to reduce the sac, and that can be done efficiently with just a couple of instruments. And also because, as I said, you can avoid tacking, so always the suturing becomes very useful, very easy. So you don't have to resort to other forms of fixation. You can suture all the mesh.
Thank you, Dr. Vilas.
Yes, sir.
Now I would like to